Support Microbe TV. It's time for our annual fundraising drive. We depend on your support to produce high-quality science videos and podcasts, and now is the time to help us. If our programs have appealed to your science interests, or if they have helped you in some way, please record a brief audio or video with your phone and tell us about it. Let us know how we empower your inner scientist. We'll use it for our fundraising efforts. Send it to incubator@microbe.tv. And for more information on how you can give us your support, go to microbe.tv/contribute.
From Microbe TV, this is Infectious Disease Puscast, episode 67, recorded on Wednesday, November 6th, 2024. Hello, everyone. I'm Daniel Griffin, and not joining me today is Sarah Dong. Sarah is off visiting China, where she says they have spotty internet. I'm not sure I believe her, right? I mean, isn't China known for having all kinds of good tech, and we're the backwards folks here, right? Still using cash and other things. So we're going to miss a little bit of the banter. I will vent because as I look outside recording this at 5 o'clock and it's already dark. So I am not a fan of losing the light. But here we are. Maybe because of that, I'll channel some of that grumpy Mark Crislip that people feel like we just don't have enough of. So let's see. And for now, on to the literature, shall we? And I'm going to start off with viral. Make sure to listen to This Week in Virology. I'm going to actually cover this article there as well. So this is an issue that's come up a lot. Viral pneumonia that is then complicated by a secondary bacterial pneumonia. And this is actually, the first author is actually a scientist with whom I published on bird malaria in the past. So here is the article, Microbial Dynamics and Pulmonary Immune Responses in COVID-19 Secondary Bacterial Pneumonia, published in Nature Communications. So what do they have to say? Well, they start off by pointing out that this secondary bacterial pneumonia is often going to be a fatal complication of severe respiratory viral infections. I'm going to say it could be a complication of even ones that are not that severe. Hospital-acquired secondary bacterial pneumonia really became especially problematic during the COVID-19 pandemic. It led to longer hospitalizations, increased mortality, and actually was part of one of the participants in this rise in the antimicrobial resistant infections. Now, I want to point this out. Copathogenesis of respiratory viruses with bacterial pathogens, they say has been recognized for decades. I'm going to say has been recognized by some of us for decades. There's still, the Occam's razor folks out there. You can only have one thing at one time. But this was really best studied in the context of the influenza virus. Now, the authors here quote this, controversial idea that the 1918 influenza pandemic that led to over 50 million deaths, there was a retrospective autopsy series that suggested that secondary bacterial pneumonia was the cause in the majority of cases. We're not sure about that, actually. It is a little controversial because a lot of folks actually just died from the severe influenza itself. So I'm going to say this is a very complex paper, so I'm just going to be sort of giving folks an introduction, but I do suggest that people take the time. This is well done, lots of complexity, really worth the time to read. So just in summary, I'm going to say that they found that the secondary bacterial pneumonia was actually characterized by changes in the lung microbiome, the host transcriptome, as well as this sort of early dominance of pathogenic bacteria, which could initially be co-detected in the upper airway. And they actually found that secondary bacterial pneumonia. In this study, it was affected almost 40% of the mechanically ventilated patients. Now, this is a little bit different than some of the other studies as far as incidence, but there was a strong association here with mortality. They also found, and this will probably not surprise folks, there was a relationship with folks that got corticosteroids, suggesting that that therapeutic benefit of that dexamethasone that we got from the recovery trial may come at an expense, and that part of that expense may be this increased secondary bacterial pneumonia. They do point out that early identification and treatment of hospital-onset bacterial pneumonia can prevent some of the adverse consequences, including that prolonged mechanical ventilation, mortality. And as I sort of pointed out, like they're actually able to detect these pathogens sometimes even before clinical recognition that there's airspace disease. They've reported that in several cases, pathogen-associated antimicrobial resistant genes could actually be detected, again, before the diagnosis of that airspace disease, before the diagnosis of that secondary bacterial pneumonia. And they're actually finding this in the upper airway. And then they actually point out that their genotype to phenotype assessment suggested using a metatranscriptomic detection to find these AMR genes. Really interesting stuff here. So the whole idea of identifying things early so you can jump in with early treatment. All right, bacterial. Be sure to listen to This Week in Microbiology. A lot of good episodes keep coming there, but we have a few cases here, a few articles to share. First one, I was actually talking about today at one of our medical centers, and this is the article: Implementation of a pharmacist-driven vancomycin area under the concentration time curve monitoring program using Bayesian modeling and outpatient parenteral antimicrobial therapy, published in Open Forum Infectious Disease. So now, our listeners are certainly aware that current vancomycin monitoring guidelines recommend area under the concentration time curve to minimum inhibitory concentration, so AUC, MIC monitoring for patients with, they say here, serious MRSA infections, but I'm going to say in general, whenever you're using the vancomycin. So here, the investigators conducted a single center, quasi-experimental, interrupted time series study of patients enrolled in the outpatient parenteral antimicrobial therapy program, the OPAT program. This institution implemented, are you ready for this? A pharmacist-driven vancomycin AUC monitoring program from September 2019, when a lot of people weren't even thinking about this, to February 2020, when, boy, I wonder what happened then. And again, resurrected it September 2022 to March 2023. Patients enrolled underwent vancomycin monitoring using an AUC goal of 400 to 600, and they did that Bayesian modeling. Patient enrolled in the OPAT program from July 2021 through August 2022 for trough-based monitoring were used for comparison. So we're getting sort of a comparison here. The primary outcome was kidney issue, nephrotoxicity incidence. And what did we find? The nephrotoxicity was significantly lower in the pharmacist-driven AUC cohort. So 6.3% versus 23.2%. So about a quadruple, a fourfold reduction in that nephrotoxicity. So this really builds, right? So about half a dozen years ago, I started going to one of the community hospitals in our area, and at that point, the infectious disease doctors are driving the bus on vancomycin therapy. Maybe this is the Mark Crislip stuff coming out here. And, within 72 hours, what percent of patients are actually getting to, and this is trough goal, even getting to trough goal, it was single digits. It was about 8%. So they jump in, right? At this point, it was a study. They start letting the pharmacists get involved. And very quickly, 88% of the time, they're actually getting to goal within 48 hours, right? So, my comment today at Rounds is like, let's let the professionals drive the bus. So we now have a couple bits of data that I think are really important. So one is the AUC MIC dosing is associated with about a 25% mortality reduction. That's huge. MIC AUC is associated with a 4-fold reduction in nephrotoxicity. And as we keep seeing time and time again, these pharmacist-driven programs are associated with much better outcomes. So suggested today, a discussion today with the head of infectious disease at that particular hospital. This should be the default. The default should be pharmacist-driven, AUC, MIC, and if a infectious disease specialist or other doctor wants to drive outside the lines, they should have a good reason, and they should have to go through some hoops. All right, have I vented? The article, Rifaximin Prophylaxis Causes Resistance to the Last Resort Antibiotic Daptomycin, published in Nature. So I was a little surprised here, right? So rifaximin, it's non-absorbed. It shouldn't be a problem. What a great antibiotic to use prophylactically to prevent hepatic encephalopathy in patients with liver disease. But here we read that this can actually cause cross-resistance to daptomycin in vancomycin-resistant Enterococcus faecium. So apparently what they find is that amino acid changes arising within the bacterial RNA polymerase occur in response to rifaximin exposure. You end up with cell membrane remodeling and this cross-resistance to dapto. So apparently rifaximin has been considered low risk for development of antimicrobial resistance, but this study shows that this assumption is flawed, and that widespread rifaximin use, particularly in patients with liver cirrhosis, may be compromising the clinical use of daptomycin, a major last resort intervention for multi-drug resistant pathogens. And these findings demonstrate how unanticipated antimicrobial cross-resistance can undermine global strategies designed to preserve the clinical use of critical antibiotics. So just imagine that, losing our daptomycin for treatment of VRE. All right, we have the article, and this is very timely. I just had a patient that we just discharged actually today. The article, Oral versus Intravenous Antibiotic Therapy for Staphylococcus aureus, Bacteremia, or Endocarditis, a systematic review and meta-analysis of randomized clinical trials, published in CID. I always worry when you've only got 3 or 4 RCTs. So here the authors conducted a systematic review of randomized controlled trials to generate, they say, more precise estimates of the efficacy and safety of oral versus intravenous antibiotic therapy for Staphylococcus aureus bacteremia or endocarditis. So they find, I'm going to say, only 4 RCTs that met criteria for inclusion. Among participants assessed for treatment failure, there was no difference between oral and intravenous therapy groups, and there were really no differences as far as adverse events. So it works just as well. It's just as safe, and really allows us to take care of these folks with oral. All right, fungal. I'm still desperately waiting for The Last of Us Season 2, so can only watch the sneak peek so many times. But this week we have the article. It's actually Notes from the Field. Trichophyton mentagrophytes, genotype 7, New York City, April through July 2024, out in the CDC MMWR. So a number of my colleagues and friends at Columbia are among the authors. So just a shout out to the first author, Jason Zucker, who's actually one of my, he was one of the fellows that I mentored through. I've also got Shauna Gunaratne, who's actually been on this week in parasitism, and a bunch of other august Columbia folks there. But what do we read? So we read that trichophyton, mentagrophytes, genotype 7, and they got a little, it's a multi-letter acronym here. An emerging fungus causes genital tinea that can be spread through sex and might require prolonged treatment. The first U.S. case was back in June 2024. And this causes this itchy, annular, scaly lesions. And they can be on the trunk, they can be on the groin, the genitals, they can even be on the face. And sometimes people mistake these for eczema, psoriasis, other dermatological conditions. And actually, sometimes they sort of bounce around before the diagnosis is made. And one of the challenges, these folks frequently require oral antifungal therapy. Now, some patients experience inflamed, painful, and persistent lesions that can actually lead to scarring and even secondary bacterial infection. Now, these infections have been reported among men who have sex with men in France since March of 2021, and previously in men who traveled to Southeast Asia for, apparently this is a thing, sex tourism. In June 2024, one of these cases in the United States was reported in a man who developed genital lesions after traveling to several countries in Europe and then ended up in California. And here we are reading about 4 additional infections that were diagnosed April through July 2024 in New York City. These infections occurred on the face, the buttocks, the genitals, and I will say were successfully treated with antifungal medications. So far, all these infections have been in MSMs. All right, and we have the article, Evaluation of Crushed Posaconazole Delayed Release Tablets in Lung Transplant Recipients, published in Transplant Infectious Disease. They have a really nice graphical abstract. You don't even need to read the article. You can just look at pictures. And so basically what they did is they looked at crushed posaconazole tablets. And what's the point? Why don't you just swallow those pills? Because what they're doing is they're giving these via the feeding tube. And then individuals with posaconazole levels at goal were compared to those not at goal, and they're looking at cost savings. As far as outcomes, about half of them got the goal levels. Rates of loading doses did differ between the groups, but were not significant. And no aspergillus was seen 1 month after starting the crushed posaconazole. So nice conclusions here. Crushed posaconazole, given via that feeding tube, right, is a viable option for folks who can't swallow pills. But there was this recommendation. They probably need a loading dose that's maybe followed by a higher maintenance dose. And this is a way to save money and treat our patients. All right, parasitic. Be sure to listen to This Week in Parasitism. We've been keeping up that cadence of every 2 weeks. And had some great guests on recently, and we'll continue to do that. But this week we have, 2 articles here. The first article, outcomes of kidney transplant recipients exposed to Chagas disease under benznidazole prophylaxis, a single-center 10-year experience, published in Transplant Infectious Disease. So these results from a single-center cohort study describing a 10-year experience of kidney transplantation in patients at risk of donor-derived Chagas. Now, the patients received, they can either get donor-derived here or they can even get reactivation, right? So we're talking about a patient population here at risk. So as such, they received prophylactic treatment with benznidazole and were monitored for transmission or reactivation. Monitoring included assessing direct parasitemia, serology, and PCR. 57 kidney transplant recipients were enrolled in this benznidazole study. 77% were at risk of primary infection. 9 patients were at risk, or 16% were at risk of disease reactivation. 7% were at risk of both. All the folks received benznidazole prophylaxis starting on the first day after transplantation. Parasitemia was assessed in about 90%, serology in about 90%, PCR in 70%, and none of the patients exhibited clinically or laboratory detectable signs of disease. A single patient had a side effect, significant side effect. It was a rash with really intense itchiness. All right. Now, I love the title of this next one, the article, Need for a Paradigm Shift in Soil-Transmitted Helminthiasis Control, Targeting the Right People in the Right Place and with the Right Drugs, published in PLOS Neglected Tropical Disease. So this is a viewpoints piece. So it sounds just like my kind of title, as I mentioned, and they even start off with a quotation. Are you ready for this? The worst form of inequity is to try to make unequal things equal. And they attribute this to Aristotle. Now, it's not clear that Aristotle actually wrote or said this and has been judged to be a misattribution, but I suspect the peer reviewers were focused on some other things. Such as the fact that soil-transmitted helminthiasis is caused by intestinal parasites that require an obligate developmental period in the soil. So what are we talking about? We're talking about roundworm, Ascaris lumbricoides, the giant intestinal worm, whipworm, Trichuris trichiura, and the hookworms, Ancylostoma duodenale, and Necator americanus, and don't forget, threadworm, Strongyloides stercoralis. And these historically have disproportionately affected the world's most disadvantaged and marginalized people. So they point out that the current approach to soil-transmitted helminth control and elimination as a public health problem is population-based, eschews adequate monitoring, assumes unlimited donated drugs, which are not optimal against all soil-transmitted helminth species, and accepts massive programmatic inefficacies. They suggest that a new paradigm is needed, and they suggest 3 policy actions. So policy 1 is, just like the title, why don't we target deworming drugs to the right people in the right place, in the right quantity? And so here they end up with another quotation. Equity's role is to prevent the law from adhering too rigidly to its own rules and principles when those rules and principles produce injustice. Aristotle. So this is actually from Aristotle's Ethics. So here they're really calling for monitoring and moving away from one size fits all. So let's look where the problem is, and then let's make sure that the right drugs go to the right people in the right place. All right, now the next is groundbreaking policy action 2, use the right drugs for the prevalent parasite species. Okay, so this seems to me pretty obvious. Large-scale deworming programs are typically based on albendazole 400 milligrams or mebendazole 500 milligram monotherapy. And here they actually discuss that in certain areas, you might want to add ivermectin or do combination albendazole-ivermectin. They point out that this has intrinsic efficacy in controlling Strongyloides stercoralis, and hence upscaling this combination therapy for soil-transmitted helminth control would contribute to the WHO targets. Secondly, they point out it's been shown that combination therapy slows the emergence of anti-helminth resistance. And thirdly, ivermectin can reduce other NTDs, including scabies, ectoparasites, and mosquito-borne diseases. And policy action 3, increase coordination, accountability, and country ownership. So really, this is an opinion. It's a viewpoint piece, but it really makes a lot of sense. All right, and I'm going to wrap us up today with what I am going to say in our miscellaneous section is potentially a big win. We read the IDSA, the ID Society of America, Infectious Disease Society of America, advocacy results in big win for ID in 2025, final Medicare rule. So I'm just going to share this from the IDSA. So I've mentioned this before, and what is this? Well, The Centers for Medicare and Medicaid Services released its calendar year 2025 Medicare Physician Fee Schedule final rule on November 1st, including a new add-on code for infectious diseases developed and advocated for by the IDSA. So this is really where Medicare, Medicaid comes up with basically what they're going to pay us and some other stuff here. This includes a little bit of a pay cut across the board for all of us, by the way. But one of the challenges, right, we've been talking about this. People go to medical school, they do a residency, and then those of us who have some degree of brilliance decide, how can I train for a few extra years and reduce my reimbursement, and then come out all ready to start practicing in my early 30s, maybe, by the time we finish all this training, with a mountain of debt. It's been suggested that maybe there's some financial issue that people are choosing the other specialties. So the final healthcare common procedure coding system has this new add-on code. The intensity and complexity inherent to hospital inpatient or observational care associated with a confirmed or suspected infectious disease performed by a physician with specialized training in infectious diseases. So CMS says the new add-on code, HCPCS code G0545, includes hospital and inpatient evaluation and management services to describe service elements including disease transmission risk assessment and mitigation, public health investigation, analysis and testing, and complex antimicrobial therapy, counseling, and treatment. The final relative value, RVU, for the new code is 0.8 time with a total time of 30 minutes. Sure, I fully understand what that means. Like, do you have up to 30 minutes to do all this? Under the proposed conversion factor, that translates to, are you ready for this? An extra $28.80 for that extra 30 minutes of time. Only an ID doc would be excited about this. And inpatient evaluation and management services where the code is appended. So this new add-on code would provide an additional payment for the following complex inpatient services when provided by, and they say, an ID physician, right? So you got to be ID trained, infectious disease boarded, and you've got to spend this time focusing on disease transmission risk, assessment and mitigation, public health investigation, analysis, testing, and the complex antimicrobial therapy, counseling, and treatment. So CMS has confirmed that this code, G0545, can be used for one or any combination of these three service elements. And they recognize that each service element may not be medically appropriate for all patients with infectious diseases. And they've clarified that this add-on code recognizes, are you ready for this, the inherent complexity for all infectious diseases and not just emerging infectious diseases with epidemic potential. So this isn't just for COVID. It's not just for Mpox. It's not just for Ebola, Marburg, etc. Now, I have to say, I assume that the majority of people that listen to the Infectious Disease Puscast actually are infectious disease trained physicians. And it is a little bit probably entertaining to our colleagues that we're so excited about the ability to earn an extra $28.80 with 30 minutes of our time. What is that, about $57 if you do the math? I was having dinner with a group of physicians earlier this week. One of my partners, Dr. Anuja Lee, was there. And I think it was a neurologist who asked us, so infectious disease, how do you guys make money? And I think the response was, we don't. And there's this wonderful joke, and maybe I am channeling Mark Crislip here. And the joke is around, how do you hide $100 bill from the different specialists, right? And the joke, is that, how do you hide it from an internist? You put it under the dressings. How do you hide it from the surgeon? You put it in the medical literature. How do you hide it from a neurosurgeon? You put it on the forehead. How do you hide it from a plastic surgeon? You can't. And how do you hide it from an infectious disease doctor or a pediatrician? You don't need to, because they've never seen one. All right. Well, let us wrap up here. That brings us to the end of this Puscast. As always, The references for this show are available at microbe.tv, the home of our growing multimedia empire. You can find the Infectious Disease Puscast at Apple Podcasts or grab it with your favorite podcatcher. So go to microbe.tv/Puscast. We'd love to get your questions, comments, and yes, send those paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders at parasiteswithoutborders.com and click on the donate button. This month, next month, so this 3-month period, we're going to be doubling your donations at Parasites Without Borders to help support Microbe TV up to a total of $20,000. Fortunately, Sarah's not with us, but you can probably find her at swindong at Febrile Podcast or at febrilepodcast.com. I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com. I'm actually doing an extra week coming up, so a little more time, extra 2 weeks coming up at Columbia. As well as you can find me on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.